Hi, everyone. I'm Rebecca Griffith, the EDDPT. Welcome back to our podcast, Admit It or Not. And I have with me today Dr. Stephen Brock. Stephen, do you want to introduce yourself?
Hey, everyone. My name is Stephen. I'm a physical therapist practicing in Tampa, Florida, aka Tampa Bay. I'm a board certified clinical specialist in orthopedic physical therapy and also a strength and conditioning specialist. I had most of my professional training has been done through the Department of Defense and through the Veterans Health Administration. I graduated from University of South Florida in 2018, so I'm a little baby. And I immediately performed orthopedic residency at the James A. Haley Veterans Hospital in Tampa.
Nice.
From there, that was fun. It was unexpected. I did not think I would, embark on the residency journey upon starting school, but after doing my first clinical at a VA hospital, I was sold. So
Love it.
Following that, I was lucky enough to get a job on one of the Air Force bases in Florida, MacDill Air Force Base. And I worked in a primary care sports performance clinic, fortunate enough to be able to start and run that clinic. And then I got sucked back into the VA system shortly after that. And in Fayetteville, North Carolina. And that is where I was fortunate enough to stumble upon practicing in the emergency department. So I was able to build a program at that VA medical center, and then was able to transfer back to the mothership back at the James A. Haley Hospital in Tampa and start the emergency program there. And that is where I am today.
I have so many questions for you about all that. First of all, do you think it's helpful to have your board certification and your strength and conditioning certification in the emergency department?
I felt like the board certification prepared me well for the primary care aspect of things, through the medical screening, the assessments, and the triage of some atypical presentations that come in.
Love it.
The board certification just had a lot of didactic material to jog your memory of things that you learned in school or articles that you've read over the years in a very concise and consolidated manner. So that's the main benefit that I found from that. And yes, having your CSCS, it helps with those higher level athletes who come in and you can really coach them on returning to activity versus some other practitioners who may not be that well acquainted with a barbell or other high performance activities, may not be able to coach someone into returning to activity after an acute episode. So that's how both of those training served me. But again, they're only pieces of paper. It's what you put into the preparation and the studying and how you apply it, and what's between your two ears is really what that means. So but yes, the didactic portions help me kind of continue to formulate my flow and how I triage those patients.
I think there's a lot of questions that I get from people about practicing in the emergency department about what kind of skill set do you need to have? And I think from what you said, having that skill set with the orthopedic specialty knowledge has been really useful for you. Do you feel like the residency helped prepare you for the emergency department, or what kind of patients were you managing during that time?
So a majority of my residency actually centered around chronic pain, which you could argue is a majority of outpatient physical therapy today.
And emergency department PT, right?
Yeah.
Those patients who have an acute exacerbation of chronic pain, or they've decided that today's the day that they can't take it anymore.
Exactly. So we had the full spectrum of acute on chronic care at infinity during my residency. But I was lucky enough that certain VA medical centers, they have embedded physical therapists in their primary care teams. And I was able to do that at least one day a week, where we would essentially be functioning in a direct access physical therapy clinic where, if a veteran came to their 3-month checkup, 6-month checkup, annual checkup, and they had any neuromuscular skeletal complaints at all, the primary physician would just halt the evaluation and send them down to us for us to do our triage and recommendations. So that was my first exposure to, kind of primary care physical therapy and how to deal with these acute presentations, because the VA is they're trying to streamline their access to care, because a lot of veterans have issues with, getting a consultation right when they have their plan. What used to be the case is they'd have to contact their primary care provider. They would put in a physical therapy consult. That physical therapy consult would then be triaged by the physical therapy team, then would be sent to a scheduler. And then by the time they get scheduled, it's 6 weeks down the road, and something that could have been dealt with acutely now is running the risk of turning into a chronic issue, and it evolved into something that it was not upon initial request. So being able to provide that direct access as a part of the primary care teams was huge. So being able to practice in that environment, and the skill set, the expertise, the mentorship I received during those clinical days is mainly how I adapted my physical therapy practice upon starting the program at the North Carolina VA, where I eventually landed. So that's the main reason how and why residency prepared me for ED practice.
I love that. And I think there's a lot of conversations too about, should there be a residency in emergency physical therapist practice? What do you think about that?
I believe there should be residencies in all areas of physical therapy practice, to be quite honest. We are trying to push our profession forward. That is what the APTA is doing. That is hopefully a lot of forward thinking clinicians in our profession have that same goal. And if we're trying to treat this and push our profession forward as, licensed independent providers, in which we are educated to be,
right, we
should, have a similar, clinical education as, providers who have that status. Most physicians, barring a couple, a couple of specialties, you have to do a residency.
Yeah.
So I believe doing a residency in all facets of physical therapy, depending on whatever specialty you want to start in, would only push our profession forward. But especially in primary care physical therapy, it is not an entry level. It is not an entry level job by any means. It takes a little bit of experience. It takes a little bit of a special skill set to be able to effectively manage these patients. I mean, I'm not saying it's I'm not saying you couldn't do it entry level, but to be an efficient, productive, and valued member of an interdisciplinary team, a residency would definitely place someone at that level faster than trying to figure it out on your own, and hopefully not pissing off the rest of the medical team, and they're just going to continue practicing status quo and not include physical therapy in their emergency department. So that is one way that I believe that there should be a residency for primary care physical therapy. And then once, pending our Practice Act developing and progressing, especially if we are, follow the suit of military physical therapists and where they truly serve as a musculoskeletal primary care provider, the residency would be extremely helpful in, guiding, mentees in medication prescription and ordering of imaging, even though that is something that's already a part of our medication. But specifically with, dosing medication in this, I think it would just ease in that transition a little bit easier than having to do a lot of self-study.
Trying to get all that in 2 years with the little clinical time. I think you're right. It's a lot to ask. So do you think that there were some gaps for you after doing this residency program that you had to kind of learn on the job still? Because I know this is like, when you're an ED PT, you're an all patient PT. You're not an ortho PT or a neuro PT or a geriatric PT. You got to do it all. So what gaps did you have to kind of learn on the fly?
Yeah, it's I went into it. It was pitched to me as essentially an acute musculoskeletal clinic. So
It's so much
I was
more
like,
though,
yeah,
isn't it?
great. And yeah, I was, the sports guy, and in school, I want to open up my own private practice clinic right out the bat and treat all my barbell athletes and open up a corner in a CrossFit gym and go cash based that way. So I was sports, ortho, everything all the way. So getting into the emergency room where, yes, you do have those cases, a majority of the clientele are geriatric patients. And then especially in the VA, essentially where every client is a geriatric patient. So honing my geriatric, management, it was an initial adjustment for me.
I'm sure.
And because especially within the VA system, it's a different clientele with those older generations. It's a lot to explain in a little bit of time, and you're dealing with maladaptive beliefs and years of incorrect medical advice and trauma, and also the psychosocial issues of the VA disability. So they may be there because they just need to re-up their disability claim for the following calendar period of time. So it's navigating that space was a hard transition for me. Well, I wouldn't say hard, but it made me reflect more on how to efficiently manage these patients as a part of a team and not be a burden to the workflow and the opening of certain rooms and continuing the productivity of the team. So
while still supporting those patients with all those different contexts, right? That's a lot to ask. So as you said, from your perspective, you still feel like you're a baby PT because you're 4 years out of school. So what advice do you have for somebody who's just like out of school or out of a residency program who wants to be in the emergency department? Like, what things do you feel like you would have done differently to prepare?
I would have loved to have had mentorship, live mentorship. And I know it's very hard to find. Dr. Stephanie Christman, who is essentially the pioneer of VA emergency room physical therapy, she was a massive help upon starting up the program and helping me and guide me and providing resources to really help establish our presence at our VA center. But obviously she's way up in Cincinnati, and it was during COVID and everything was virtual, and she, I think, is either a reservist or participates in a couple military deployments every year. So there's periods of 6 months to a year where she's AWOL and I don't know where she is. So it was in the midst of those constraints and during 2020 when we started this up. So I had her as a resource, but I really wish I had someone on site who could kind of just bounce ideas off of, because it was me and myself and I just trying to make this program work, and I was bouncing off of the ED director and it's great, but from a rehab perspective, I wish I had like-minded people at my site to bounce ideas off of. So
well, I want to acknowledge you for persevering through all that and creating a successful program, because it's not easy when you're an experienced PT. It's not easy when you're going up against a huge system like the VA. It's not easy to start something new, particularly in the midst of a global pandemic. So congratulations to you for being successful.
I wish I found EPT earlier. It could have eased some growing pains for sure.
So where do you see your program going next?
Well, so the program that I started in Fayetteville at the North Carolina VA, they've expanded to full-time physical therapy coverage, which is unbelievable. So, and they rotate through different clinicians, so it's not the same person for 40 hours a week, but they've expanded to full-time coverage. And that it was due to kind of family circumstances why I had to leave North Carolina. So if it wasn't for that, I would probably still be there, trying to, run and hone and enhance that service there.
But instead you're spreading the good word to Tampa.
Yeah. So we're currently, slowly building the program here. It's, I like to say this, the slogan for the government is hurry up and wait. So
that's fair.
So I'm currently embedded 2 days a week during peak hours, which is a 4-hour window in the middle of the day. Most of their musculoskeletal admits, present between 10 a.m. and 2 p.m. usually. So that's when they place me down there. And so I essentially have 4 hours to just see new patients and perform either telephonic or virtual follow-ups with previous patients. So
that's cool. I have not heard of that yet in all of these different EDPT models. Tell me about that.
Of the virtual follow-up.
Yeah, that you get to actually follow up with your patients. How cool is that?
Yeah. It's something that I tried in Fayetteville, just trying to wing it. And again, the goal for me and the goal for just my vision as a emergency room practitioner is trying to instill self-efficacy in these patients, because no one knows how to self-manage their symptoms. No one. And it's not their fault. No. They've been brought up in a system where everything's reactionary, everything's negative, and everything generates a maladaptive belief of their condition, especially with low back pain, which is the main thing that I focus on.
We've kind of set them up to fail.
Yeah, it sets them up to fail. So my goal is how I can make a serious dent and impact, on this whatever condition they're presenting with. And if I can follow up with them and carve out, a 5 to 6 minute, telephone conference with them, I'm going to do it, because the VA, we're luckily not that constrained with workload, and we're not, you must see, 2 evals an hour and this and that. It's, you have the flexibility to cut out time for that. And in Fayetteville, I actually had I set apart a clinic where I was able to schedule appointments, whether it was a telephonic appointment or a telehealth conference where we would do a video chat, and it would be a set schedule. You'd see it in the system. But in Tampa, we're still, the system administrators are still, let's not do too much at once. I've been here since November. It's kind of been a long time. Let's hurry this up. But I don't have that flexibility yet. So I'm essentially just keeping track of, I'm making Outlook appointments with these patients and just saying, I'll call you around this time next week. And I would think that they would not remember that, but I would say 85% of the patients pick up the phone a week later, even if I'm, call them 45 minutes late. So I guess that's one good thing about the VA. The patients know if you get a call from the VA, you better answer it, or you'll never know how long you're going to be on hold again. So I think they see the kind VA
works in answer. Your favor a little bit.
Yeah. So I sprinkle in some phone calls in between patients. And then with people who really have some movement issues and maybe the higher level people who want coaching on something specific. I mean, I know the ED is not the setting for, outpatient physical therapy, but the goal for me is to hopefully prevent them from needing a whole course of care in outpatient physical therapy. If I can help you in 1 to 2 quick follow-ups that take grand total of 10 to 15 minutes, I'm going to do it, because A, the VA system supports it, and B, it's the best thing for the patient. And I should probably have switched the order of those. A, it's the best thing for the patient. That's what I meant to start with. And B, it works within the confines of the VA system. So
as you're helping decrease the burden on the system and on the patient by meeting the patient where they are and improving throughput in your system.
Yeah. because
perfect.
yeah, I definitely feel strongly towards the fiscal responsibility of our service in the VA, because the VA ends up sending millions and millions of dollars out in community care, physical therapy every year. So we try to keep most of our patients in. So if we provide this excellent service in the VA, from the emergency room, because they're not used to seeing a physical therapist in the ED to say, oh,
Right.
I didn't know you guys are here.
Yeah.
So, and then for them to get a follow-up the next week is, oh, no provider's done that before. It's just, yeah, well, we're just trying to provide a good service for you. So it optimizes the quality of care and improves satisfaction and function, as you know, how early intervention works. So
are you collecting any outcomes on that?
yes. So the main outcome that I'm collecting, so this may trail off into a different project that I'm working on. The whole reason why my initial detail to the emergency room in Fayetteville was the emergency director. He was working to help get his department. There's some geriatric accreditation for emergency departments in the VA. I think it's called Grec Approval. Is that in the private sector as well?
Yeah, so I think it goes through the Academy of American College of Emergency Physicians. It's their certification program.
Yes. So in order to certify that center, you have to offer extended rehabilitation services or special services, one of those being occupational therapy or physical therapy embedded on site, ready to evaluate while the patient's going through a course of care in the emergency department. So but a part of that is also using special technology to help reach patients and increase their health literacy once discharged, to help, like you said, reduce visits, reduce advanced imaging, and reduce opioid prescription, this, that, the other. So I'm tracking data on an app that we developed to help treat acute on chronic low back pain. And we're tracking functional outcome data, pain, and opioid prescription, and advanced imaging prescription, and repeat visits to the ED. So again, I just got the project up and running in mid 2021. So our sample size is not yet built up yet, but I'm keeping track of functional outcome measures. I initially started using the patient specific functional scale within the ED. I just love function. I try to relate everything to function. I think everyone should. And try to redirect patients, focus on their function instead of their pain.
That can be important in the emergency department specifically as well, right? Because so many patients are having an acute pain crisis, and to be able to help them redirect to the function that's meaningful to them, I think is really valuable.
Yeah. So, but I modified that to a general rating of change scale, because it got cumbersome to, all right, you listed 2 functions, let's get 1 more, that's not the setting for that. So we're tracking, just general rating of change 0 to 100%. And 72-hour readmits to the ED, because that's a huge issue in the VA. I would say about 25% of my patients, I see an ER note, within the week prior. So we're trying to instill, like I said before, self-efficacy in these patients. So
I do have patients who may have come to the emergency department 22 times in the last 12 months. And I often wonder, where are we failing these people? Is it with access to care? Is it with health literacy? What is the crux of the issue? So it sounds like you're able to get at that a little bit.
Yeah, because essentially the ED providers, are you dying? No. Okay. Toradol, Medrol dose pack.
Peace out. Yeah, exactly.
So that's why I think we play an important role. But yeah, so I need a pretty large N, a couple hundred I was working with a team and some um, some, data analysts, and they gave me a pretty large minimum sample size number. So I'm slowly ticking up that number for patients who choose to enroll in this program for low back pain. So it's a text-based app that actually, they can respond to daily. They get text, and they can self-report outcome measures, pain. It also sends.
Is this the Annie app?
Yes. Yeah. It's the Annie app that the VA, developed. And it's not just for low back pain. They use it for other conditions like congestive heart failure, diabetes. They can upload their blood sugar readings and send it in, and the providers will be able to see it. Yeah. So it's really cool for people who are technologically advanced, not really technologically advanced. If you have a smartphone, you can do it, but a lot of veterans now love, messing around with technology. So if they can use a cutting edge piece of, technology to help get them more involved in their healthcare, then we're going to try to optimize that. So they approached me and they wanted me to develop a protocol for low back pain in the emergency room. So that's what we did. And it's a 2-week protocol. It starts off with a little bit of education to help dispel fear and set expectations. And the thing that was hard for me was because I hate cookie cutter programs. I hate everyone gets the same thing, but to large scale an initiative, you kind of have to compromise in the middle a little bit. So I was able to, there's a certain movements that I think everyone should do, really just 2. And then there's a cue in the app to also perform the other movements discussed within the physical therapy eval that you had in the emergency department. So it kind of blends that cookie cutter with individual prescription there, and then it's a graded walking program that's individualized to the patient based on their tolerance on day 1. So I obviously don't give this out to every low back pain patient that walks in, and they have to be appropriate for it, and they have to consent to it. So but that's the only data that I'm tracking right now. I should probably track more. I'm mainly tracking just our utilization right now, because the department just wants to see, hey, well, is there a need here? Do we need physical therapy service? How many staff do we need to allocate to the emergency room? So I'm tracking all of those things in the background, and to show, to justify, hey, yeah, we could use 3 PTs on any given day. So just with the sheer influx of patients that we see that are appropriate. So, but yeah, the more specific data in regards to, outcome measures is slow, but it's coming along.
I think that's amazing. It sounds like you're doing some really amazing things to help transform one of the arguably more difficult areas of the healthcare system. It's hard when things run in a huge system. It's hard when there's access issues, and it's hard when you have patients who have so much to carry with them in the terms of comorbidities, stress, trauma. So it sounds like you're doing an amazing job.
Well, I appreciate that. I wouldn't be able to do it without, my mentors and the team that I have around me that supports me. And that comes down to my physical therapy department, and even my fellow colleagues in the emergency room. The physicians there are huge proponents of physical therapy. And that was something that took me off guard at first, because I thought I would be walking into a battlefield and, butting heads with people all the time. But I don't think I've had one incident where we disagreed. So it's been,
that's amazing.
Yeah, that was probably my biggest surprise. But yeah, all this wouldn't be possible without the support of and the interdisciplinary harmony that we have.
I think that's my favorite part, really, is that working in the ED is a team-based sport, which is kind of a far cry from seeing yourself in the corner of a CrossFit box, right? All on your own, a one-man show. So it's awesome to me that
how selfish of me to think that.
Well, I loved it. I mean, but that's also still a possibility for you too, right? Like you can use your skills and talents in multiple areas of the field, which is amazing.
Well, that's the great thing about the VA is you have great work-life balance. So it affords you that opportunity to maybe, run a little clinic like that 5 to 10 hours a week, and you're not encroaching upon your family time. So It's definitely not there are definitely plans for that. Definitely kind of doing some version of that now intermittently with, random clients, but
Yeah, filling your cup on
um,
the side.
yeah,
I love it.
but right now it's full steam ahead ED. I should probably start calling it ER because some people give me funny looks when I keep
I
saying
know.
ED. So.
Well, it's funny because pelvic health therapists are always like, no, that's not like what we mean. And then, but like most of the people that work in the emergency department would never call it the ER. You know what I mean? So it's hard to get the terminology right for people. So, all right, are you ready for the case?
Oof.
Oof.
Probably not.
All right, well then I'm gonna give you a case. How about?
Okay.
And you tell me how you would manage this particular case, okay?
Okay.
I'm trying to think of a patient I had that should have been at the VA that wasn't. Okay. Let me see. I had a patient who was a World War II veteran, which, can we just be honest that those
They're
are
the
like
best.
our favorite people on the planet? They may say some like really shady, offensive things sometimes, but they're like cooperative and kind and helpful and like hysterical. So this
They
gentleman,
don't make them like that anymore.
well, they don't. And this gentleman that I evaluated, he was there for ankle pain because he had been a paratrooper, and he told me that there's always a last jump for a reason. that they always have the last jump is always the last one for a reason, and it's never a good reason. So he had a chronic history of ankle pain from an ankle fracture, I don't know, probably 50 years prior to this incident. And he was presenting for ankle pain and falls. So what do you want to know about this guy from your perspective? What would you do next? What's our next step?
Yeah. Well, before anything else, I would just want to kind of get a little picture of why he's falling. I need to rule out any central signs that are potentially causing these falls, and make sure that there's no acute insidious process or myelopathy that's leading to this instability. So I'd probably try to get down to the etiology of his dizziness first, and then do kind of a little vestibular screen there. But I would also try to screen the ankle, make sure, is this just chronic pain from your fracture? Is this a new onset pain that you haven't felt before? Like, I would try to I don't know what his other comorbidities are. I don't know if he's a high clot risk or not, but I would, based on what you told me, I would want to figure out why he's falling and why he's dizzy.
Yeah, 100%. And I feel like you cheated because this guy did end up having cervical myelopathy. Whoa. In this particular case. Yeah. And really kind of complaining of ankle pain, but with further evaluation, like having some clonus, having some instability, having positive Hoffman, some hyperreflexia, and like had a history of cervical stenosis. So in his case, he was kind of ignoring some of those warning signs, like the clumsiness and the increased falls. Like he was just attributing that to his age. And as you know, with some of those World War II veterans, they're not fazed by a lot, right? Like it takes a lot for them to seek care. And I also feel like sometimes they're not even, it's more of a social visit sometimes as well. Like this gentleman really just wanted to speak to me mostly about his wife and tell me about how he met his wife and where they met and where they got married during the war, because she had recently died. But so
like, bro, you have myelopathy.
There was like this combination of like things happening for this patient. And instead of just being like, okay, well, you need a walker, let's send you to rehab, like doing that examination that probably only a physical therapist would really think to do to help stratify fall risk. We're able to kind of identify some of those upper motor neuron issues and get him the imaging that he needed so that he could end up having surgery to kind of correct some of those issues for him. So you like nailed it. I was not expecting you to say that. I was expecting you to be like, well, I would take a look at the ankle and we would, you just like, you definitely had a top-down approach. That's awesome.
Well, I thought of another case that I didn't directly deal with. Since I split my time in the ED and acute care, I missed this guy in the ED. So I need to stop it. I'll be better next time.
You're good.
I missed this guy in the the ER the day before, but I saw him in acute care the next day, and I'm like, man, I wish I saw you in the ER the day before, and we potentially could have, prevented this admit. But it was this young guy, 56-year-old male. He just started having just unrelenting back pain that positionally he couldn't really shake it. There were some positions in bed where it would alter it temporarily and then it would flare right back up. So it was a little puzzling. So I tried to put him through some positions. He said his legs weren't really feeling weak at all, and it didn't affect his ambulation. So I took his word for it. So I don't know. Do you want to take a shot at this? I didn't really paint that picture too well. I just thought this is something very odd that I've never seen before, and something to keep on the lookout, especially during these COVID times. He ended up testing positive for COVID.
I was going to say the flu. I had a patient like that who had the flu. I thought it was COVID.
No. So I did an evaluation. He could still ambulate independently. He could, walk to the bathroom in his room and back, but it was limited by pain. And there weren't really any upper motor neuron signs at all, but just I could not change the pain. So it was
musculoskeletal.
Yeah, I was a little sketched out about it. Turns out he had, transverse myelitis secondary to COVID.
Ooh.
So, wow, would you prefer your lungs or your spinal cord? I don't know.
Gosh, well, they're saying that one of the new variants presents very much like meningitis.
Yeah.
So that's something to be on alert for in the emergency department as well.
No, and I talked to the neurology department. They said, this is really rare, but over the last 2 years, we've actually seen this a couple of times. So
that is good to know.
So I just, wow. So that's for anyone out there practicing in the acute care or the ER, just be wary of your COVID positives and intractable back pain, maybe transverse myelitis. So
that is crazy. That is good to know.
No.
That is an excellent case. And in your case, the patient was admitted. Yeah. So in both of our cases, I love it.
Admit,
definitely admit. Well, I appreciate having you on today. It was a great conversation. It sounds like you're doing amazing things in the VA system, and I can't wait to have you back once all your data collection is done so you can share your outcomes. How does that sound?
I would love it and be honored.
Right. Thank you so much.
Thank you for your time and everything that you do as well.
Oh, I appreciate it. All right. Thanks so much.